association, we have a thing, it's called You're the Cure for Heart Disease. Each and every one of us is the cure. Be the example in your family. Let them follow you. You have the cure for heart disease in your hands. Thank you for your time. Because heart disease is so prevalent, because heart disease is so prevalent, we all need to know CPR. CPR can be done in just a few minutes. Because of new infectious diseases and because of COVID, CPR can be done with hands only. It's been proven that hands-only CPR can be effective. To be real, if you come across someone who's down, you probably don't want to put your mouth on a stranger. And I'm gonna keep it real, I don't. But if you come across somebody who's down, if you witness somebody who has gone down, the first thing, the very first thing, this is step 1 of step 2 for hands-only CPR. Step 1, call 911. If someone else is around you, don't say someone call 911. You call 911 so that you know it's been done. You're looking for breathing. You're making sure they really are not conscious. You have to press down on the chest, hard and fast. And I'd like for each of you to try this after this is over, because there's this, everybody's heard of chest compressions, right? I don't like the term chest compressions. It's heart compressions. You are not compressing the chest. You want to actually compress the heart. You're beating someone's heart. You're not compressing their chest. I don't like the term chest compressions. Everybody know the tune Staying Alive? Okay, that's the beat. I wish I had it tuned up so we could play it. But the heel of your hand in the center of the chest, your elbow straight, and with your whole body weight, you are going to compress the chest. I'm going to show you how it looks right and it's not. But this is, people see this all the time. You're compressing the chest. You are not compressing the heart. Oh, good. All right. Okay, now, when I press hard enough, you're gonna hear a click. It's your whole body weight. This looks right? It's not. Listen to this. That's hard enough to make the table move. That's hard enough to make this whole table move. Now, look at me. This is not easy. It's much harder than you think it is. But remember, you're feeding someone's heart. If you see me, I want you to know how to do it right. Because if you see me on the street and I'm down, I want to know that you know how to beat my heart for me. Each of us can save a life, but we have to do it properly. It's hard and fast. It is not, it's not this. It's not that. It's not even this. And that looks like it's hard. It's all of your body weight. You're beating someone's heart. If you do it that vigorously and that hard, you're circulating oxygen through the body. Especially if you witness someone go down, there's still enough oxygen in the body that you can circulate by doing heart compressions. You know I don't like chest compressions. You can still circulate enough oxygen to keep them alive. You've already called 911. That was your first step. Help is on the way. If you get tired, and this is tiring, if you get tired, can you help me? Get somebody to help you. And then make sure that they're doing it right. Because they may have never done it before, but you guys all know how to do it. And I want you to practice when we're done. But make sure that whoever you ask to help you is doing it right, because we're saving our lives. Here's a cookbook that somebody's gonna get.
Somebody.
Thank you.
Somebody gonna get that cookbook. Sister Joan, thank you a million times, and she will have an opportunity, yes, and what I would say is a lot of what you said about heart disease also applies to stroke. So, heart and brain actually goes hand in hand, especially when you think about cholesterol and blocked arteries.
So I fixed it up, but it's not fixed pattern.
Certain populations. So take that to heart. I have a cousin in the hospital now from a stroke, and I have another one, and he's younger than me. He's 57, and I have a nephew who just had from a heart attack. So take this to heart. He's 40.
Can I just interject something? When you were saying the compression going down, so one of my biggest things, I did it on my dad. He passed, but I did it on my dad, but he had just had open heart surgery. And so as I was pressing all my body weight, everything was cracking.
I'm so glad you said that.
And the paramedic said,
I'm
it's
so
better
glad
to
you
get the
said
heart
that.
started.
If you're doing heart compressions effectively, you may start to hear a crack. You have broken the lungs. That's okay. It's okay to break ribs. It's okay to break a rib, because ribs will heal, but a heart that has stopped beating will never beat again if you don't help. So when you hear crack, 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 it's unsettling. Keep going. The ribs will heal. Thank you.
Yeah, that's what they told me. So.
And we're all
Any
witnesses.
questions? Go
We're
ahead.
all witnesses what happened last year with that NFL football player.
Right.
How
Yes,
they immediately, had they not immediately jumped right in and did what you said, he would not be here today.
Right, and more people have learned CPR since Damar Hamlin arrested on the football field than ever before. And because heart disease is the leading cause of death in the United States, cardiac arrest is way more common than you would think. So please, no CPR. Hands only is effective. If you want to learn the classic CPR with the mouth-to-mouth, by all means do that, but until or unless you do it, you know hands only.
Thank you.
Can I get that, please? No, it's not for healthcare ministry people.
Well, we're gonna take an opportunity, thank you again, and she'll be over there where you can practice, you stand for the, full event. But we're gonna take the opportunity to introduce a couple of our vendors. We have several vendors, and we wanna thank you all for coming in, all related to, total body health. And there are a couple vendors who are outside that I wanted to speak, so that you'll know that they're out there. So if someone from Family Christian can come up, we have a dentist who's out there, doing dental exam, also the community health services. And then coming behind them, Advocate has a van out there too. We're gonna have, you come up next to speak about Advocate and the services they have outside too. I'll stand out your way and you all have 2 minutes. 2 minutes and a hook. We would do that.
Hello, we're with Family Christian Health Center. I'm Selena. I'm a community health worker, and this is Dr. Irving. He's the dentist at that center. So we are a nonprofit health center in Harvey, and we provide medical services, which is primary care, dental, and behavioral health services to Harvey residents, as well as underserved areas in the South Bend area. And then right now we are doing COVID vaccinations right now outside. So you come to our table. We do have COVID test kits as well for you all. And it's important for you all to take the COVID vaccine. The new bivalent booster has been available since September of 2022. And I know a lot of people probably don't know about it, but that is the newest booster that's been out since September 2022. So if you haven't gotten that shot, it's very important. It will help protect you from all the strains of COVID. And right now, we are just doing the bivalent boosters now. So everyone, even if you haven't gotten your shot, you would just take one shot. So that's been the thing for now, for Moderna and Pfizer vaccine. I know Johnson was doing the one shot already, but Moderna is now doing just the one bivalent booster shot. Okay?
So if you had Pfizer, can you get the Moderna?
Well, you can switch. Yeah, you can switch. We have our nurse on board. You could ask them a question. Sorry. And then, so we are having a farmer's market at our clinic. I know there's a farmer's market out here. So we do have that often at our clinic. We are having that next week, next Thursday. And then we are having it every month until September. So if you are looking for a doctor, come to our table. We can schedule an appointment. And Dr. Irvin is going to speak a little bit about the dental services we have.
Yeah, so I'm Dr. Craig Irvin. I'm one of the dentists out at Family Christian in Harvey, and we have a Linwood location as well. We're out there. We have dental screenings out there on the mobile van today. But more important than that is just to make sure everybody has a dental home, whether it's with us or whoever. Just make sure you're seeing a dentist regularly. As we heard about heart disease earlier, periodontal disease is one of the main indicators of heart disease as well. Over 80% of people that have heart disease also have periodontal disease. And so you just want to make sure that you're staying on top of, everybody in here has teeth or had teeth at some point in their life, right? and so we want to make sure that we keep our teeth as long as possible. And so staying on top of seeing the dentist and practicing good, brushing and flossing home is very important. And can go a long way. A lot of people don't think the blood that's in your mouth is the same blood that runs throughout your whole body. Think about how easy it is for your gums to bleed. That opens up a way for infection to get into your bloodstream and can travel to anywhere in your body. So we just want to make sure we're keeping everything as clean as possible and staying on top of good dental health and seeing a dentist regularly.
And then we also have Advocate here who has a van outside. Okay. Tell them about the services are out there, and then we'll have our next speaker. Thank you.
My name is Maisha. I'm from the community outreach with Advocate Children's Hospital and Advocate for Adult Side. We do have a mobile unit outside. We're doing blood pressure, glucose screening, and cholesterol screening. It's going to check the good cholesterol and the bad, and that's the HDL and LDL. So like she was saying, you go out there, you can know your numbers, basically. And then that's about it.
Thank you.
So our next speaker would be on pre-diabetes, Diane Danford. Dr. Diane Danford.
Yeah. Okay, thank you. And then we'll keep announcing our vendors as we go. But right now, we're gonna introduce to you Dr. Danford, Dr. Diane Danford. She's also internal medicine. She and Dr. Smith worked together for years. She's one of the lucky ones. She retired. Loving life now. So Dr. Danford is gonna speak to you about pre-diabetes, which is important to all of us in diabetes. It also relates to cardiac health. So Dr. Denver, if you can just introduce yourself and give them a little bit of your history.
I'm Diane Danford. She said, internist. I went to my hospital on 36. So prior to that, I did my microbiology at the University, and I decided to like issue and can be a serious health issue, recently. So if I can have the first slide, we spent a couple of minutes talking about diabetes. I don't know if any of you are diabetic, in the audience, but as everyone probably knows, diabetes happens when you have too much blood glucose or sugar. And we also may know that glucose is like the energy source that our bodies use for all of our cells to function and do whatever the tasks are to function in our body. There's a hormone that's produced by the pancreas called insulin. Insulin is like a little truck or a car that carries the glucose from the bloodstream into the cells so the cells can utilize it for energy. To the next slide. Now,
I'm like, she blew this up really big, so I was
okay, thank you. So as you can see here, when your body doesn't make enough insulin or doesn't make any insulin at all, that leads to the diagnosis of diabetes. And over time, when you have too much glucose or sugar in your blood, you develop a myriad of complications. So diabetes is really a horrible, horrible disease. Just from this one disease, you can develop strokes, as Nurse Jean talked about. You can have heart attacks. 80% of the people on dialysis are diabetics who didn't take care of themselves and destroyed their kidneys. You can lose the ability to feel things, and a lot of those diabetics may have sores or cuts on their feet or their legs, and they don't know it until they become infected or get really bad because they didn't feel it. Fortunately, because of the effects on blood vessels, you also have circulation problems. A lot of people have decreased circulation to their feet and legs. You may have had friends or family members who've lost toes or half their feet or half their leg because of poor circulation and diabetes. And it just really decreases your ability to heal from any kind of wound or infection or cut or anything like that. So diabetes is really a horrible, horrible disease. And if you are diabetic, you really have to manage it well, make sure you take your medications and do all the other things your physician recommends that you do in order to stay healthy. Next slide. So I said diabetes is of course having too much glucose in your bloodstream, and there are actually two types of diabetes. Type 1 is what they call insulin-dependent diabetes, and for some reason your pancreas can't make any insulin. A lot of times it could be some sort of viral infection or inflammation that destroys the pancreas's ability to make insulin, so you have to get insulin injections. It used to be called juvenile diabetes because a lot of times this would happen in young people. They would have a virus or a cold or something that would affect their pancreas so that they can no longer make insulin. So they're totally dependent on insulin from the outside, on giving insulin injections in order to regulate their sugars. And then there's type 2 diabetes, which is also called non-insulin dependent. So in type 2 diabetes, you may be making insulin, but you may not make enough insulin to take care of all the sugar that winds up in your bloodstream. Or the cells may be resistant to getting the insulin, for using the insulin to get the sugars into the cells. So between not having enough insulin and or being insulin resistant, you develop type 2 diabetes. And for that, there are myriad now of medications that people take to control their diabetes. Ultimately, if they don't do other things that need to be done, they may wind up having to take insulin as well. But it's not that initially they would be totally dependent on insulin. You may have seen in the news lately, though, there are a lot of people that take certain diabetic medications. They can't find it because all of the shishi-foo-foo people in Hollywood are using it to lose weight, which is okay, except now our diabetics are like, oh, I can't get my medicines because Kardashians are making it go. But anyway, if you really are diabetic and you maintain your lifestyle changes that you started and take your medication and be able to still live a healthy life. Now, again, the question is pre-diabetes. Why is that such a big deal now? Well, it's a big deal because it is a very serious health condition now, and it can actually lead to type 2 diabetes. There's over 96 million Americans that are pre-diabetic. The problem is 80 to 90% of them don't know that they're pre-diabetic. And the only way you can find out is to test it. So what is pre-diabetes? Well, it's not normal, and it's not being a diabetic, it's in between. So your sugars aren't normal, but they're not high enough to be called diabetic. So now you're pre-diabetic. And pre-diabetic is actually a good place to be because this is a point in which you can actually reverse this condition and not have to worry about leading down that road into there are lots of things that you can do if you find out that you're pre-diabetic, which you want to do so that you don't wind up with the serious health problems that I mentioned later, like your strokes, heart attacks, kidney disease, losing your getting amputations of your toes and your feet. And so you really want to, if you find out you're pre-diabetic, you really want to sort of nip that in the bud right away so that you don't wind up being diabetic. So what are the symptoms of pre-diabetes? As I said before, 80 to 90% that are pre-diabetic don't know they're diabetic. People don't have any symptoms. It's like Nurse G, she talked about the fact that a lot of times people didn't know they had heart disease because they had a heart attack until they died, because they weren't really sort of keeping up with their health. So you may not have any symptoms for years. I mean years. And if you do have symptoms, you can be tired, thirsty, urinating a lot, have blurred vision. But to my way of thinking, if you develop the symptoms, you're already well on your way to diabetic. That's not really one to go. Now you see here, there's something called a blood test you can do called hemoglobin A1C. And what that actually does is measure the amount of sugar that's in your bloodstream. And how does it do that? Well, we all know there's the red blood cells are made up of this protein called hemoglobin. And sugar can stick to this hemoglobin in the red blood cells. So depending upon how much sugar you have stuck to the blood cells in your body, they have now been able to determine that based on the percentage of blood cells that have glucose stuck to them, they can determine how high your sugars have been averaging for the last 2 to 3 months. And so that is one of the tests that we do to try to identify whether a person is diabetic or now, in this case, pre-diabetic. Next slide. So what are some of the causes and the risk factors for diabetes? Well, if you're over 45, you're at risk. If you're Black, Latino, or Native American, if you're overweight or obese, especially if you have a lot of weight, in the middle here, where we tend to kind of accumulate weight. If you eat a lot of red meat, processed foods, if you eat a lot of starchy foods, not enough fruits, not enough vegetables, and if you don't exercise at all. And also if you're a family member or family members who are diabetic, that can be an increased risk for diabetes as well. As mentioned earlier, you need to know your cholesterol. Cholesterol can be a risk factor for diabetes. If you had something called gestational diabetes, meaning when you were pregnant, you developed diabetes and they treated you, and then once your baby was born, the diabetes went away. You still are at increased risk for developing diabetes. If you have a big baby, over 9 pounds, again, that could be a risk for diabetes. And if you have sleeping problems, not only does it affect you develop heart disease, but it can also cause hypertension or high blood pressure. And if you have something called polycystic ovaries, which again is a problem with the hormone primarily in ladies, this can be a risk factor for pre-diabetes. So the question becomes, how do we find out if we're pre-diabetic? There are 3 ways. One is to check your fasting plasma glucose. So what that means is, let's say first thing in the morning, your doctor says, I want to check your fasting blood sugar. And And also they do that with cholesterol as well. What you do is before you eat breakfast, before you do anything, you go and get your blood checked. If you're a normal person, when you wake up in the morning, your blood sugar should be between 70 and 100 milligrams per deciliter of blood. If you're diabetic, it might be over 126. But if you're pre-diabetic, you can see it can be between 100 and 125. So if you take a fasting blood sugar and your sugars fall within that range, 100 to 125, you're pre-diabetic. The second test that can be done is called the oral glucose tolerance test. And what you do is you go into the lab, they check your fasting blood sugar, and you drink a really sweet, sugary drink. And 2 hours later, they check your blood sugar again. So if you're a normal person, your blood sugar should be less than 140, meaning your body is producing enough insulin to take care of the sugar or glucose that was in that sugary drink that you had in the last 2 hours. If you're diabetic, your blood sugar will still be in the 200s. But if you're pre-diabetic, your blood sugar can be between 140 and 199. And that's 2 hours after you've taken in a lot of sugar. And then that third test is the one that I described previously, the hemoglobin A1C test, which again gives you the average blood sugar level that's been in your blood over the last 2 or 3 months. If you're a normal person, most people's A1C, or what they call glycosylated blood sugar hemoglobin, is 5.6 or less. If you're diabetic, it can be 6.5% and above. But if you're pre-diabetic, your A1C might fall between 5.7 and 6.4. Now sometimes it is kind of in that, you couldn't hear me. They want to hear out here.
Yeah.
Hello. Sometimes, if you're pre-diabetic and you fall in that range of 5.6 to 6.4, your physician may give you a chance to kind of work on things, try to get it down, and might repeat it in a couple of months. But if it's still high, then you know you've got an issue that you need to deal with. So what can we do in order to help reverse this? First of all, just remind you, there are complications to being a pre-diabetic. The most important complication is that you become a type 2 diabetic. And then you have to worry about all the other complications that come from that. Blood pressure, kidney disease, blindness, loss of limbs, something like that. The most critical point that I want to make is that you can reverse prediabetes, and that's what's the most important thing to note here. And how can you do that? By changing your diet, by eating healthier foods, less red meat, more beef, fish, turkey, chicken, green leafy vegetables. You kind of cut back on, all the good stuff. Corn, potatoes, pasta, bread. You like to take my life away, but no, actually I'm giving you like that. Decrease the amount of what they call complex carbohydrates that you eat, because they literally turn into sugar in your body. And so when you're eating that extra helping of french fries or potatoes, that second ear of corn, or eating a lot of fried foods, eating a lot of rice, a lot of times, all of that turns into sugar in your body. And if your body's having problems making enough insulin to cover that, then you're pushing yourself over into diabetes. You want to lower your blood pressure, lower your cholesterol if you can. Because remember, all of these things are minimizing the problems you may have in terms of getting a stroke, or having a heart attack, or kidney disease, something like that. Now, if you're having some trouble making these lifestyle changes, you can take some diabetic medicines. Here they have metformin, which a lot of people are familiar with. But if you make the lifestyle changes that you need to make, and you're able to reverse the prediabetes, you can also get off that medication. I mean, I've had patients who came in, and when I first checked their A1C was 9 or 10. And I kind of read them the riot act. I actually beat a guy with his hat one day when he came in. But 3 months later, when he came back, his A1C was down to 6. And I said, what did you do? He said, I did what you told me to. treat your pre-diabetes, and even better yet, reverse your pre-diabetes, you're saving yourself a whole lot of problems that you might develop later if you become a diabetic. And if you don't become a frank diabetic, you still have to be concerned about blood pressure, heart disease, having a stroke, all of that feeds into each other. So if I can have the next slide, which I think is actually the last slide, let's see. It says, what are some tips to prevent prediabetes? Well, one is to stop smoking if you can. The second one is to only drink one alcoholic beverage a day. The third one is to exercise. Again, Ms. Jean gave you some exercises that you can do in the chair. Or get in front of the TV and spend an hour watching your favorite TV show and just walk in place for a half hour, 45 minutes in the house. Or walking for 30 minutes, that's all you have to do, 5 days a week. And then eat foods that are low in carbohydrates and sugar, obviously sugar. Also, like I mentioned, starchy foods, rice, potatoes, corn, pasta, bread. Decrease your salt intake, all those things impact your blood pressure as well as diabetes. And then some changes you can make in your diet to reverse prediabetes is instead of eating or drinking sugary drinks, drink water, coffee, or tea. And even though I like sodas, diet sodas, they're really not that good. They're not good diet. So, eat whole grain and whole grain produce instead of processed things like bread, cereal, potatoes. Eat good fats. So you hear a lot about nuts, oils, avocado oil, olive oil. Those are sort of like the good fats, and not margarine or fried foods or baked foods. And instead of processed meats and red meat, eat nuts, whole grains, chicken, turkey, and fish. So what I have here is a little test that everyone can take to see if you're at risk for developing prediabetes. If you take this test, and the test says, oh, yeah, you're at risk for developing prediabetes, I want to urge you to call your healthcare provider and say, I need a glucose test. And they say, why? Because I think I may have prediabetes and I want to be able to jump on it right away, reverse the situation so that I can stay healthy. And any questions? All right, thank you for your time.
Thank you.
Get on it, figure out, so you know what to do.
So once you've been diagnosed as diabetic, your numbers go back to normal. Are you still considered diabetic
If you're still taking medication, I would say so. But it's very good if your numbers do go back.
I mean, I was in a situation where I was taking a lot of weight because my numbers were reversed. So when I saw my doctor last year, he said, you still diabetic. I mean, even though your numbers are normal, once you are considered diabetic.
Right. And she's correct. There is no cure for diabetes. That's why I'm stressing the fact that if you know that you're pre-diabetic, you can cure, in a sense, pre-diabetes. You can't cure diabetes, but you can definitely reverse if you're pre-diabetic. So that's why it's so critical that you find that out, so that you start making the lifestyle changes. Now that your numbers are back to normal, excellent. You can decrease the diabetes. So if you're not taking anything, that's awesome, but you always have to keep them back. So you want to always maintain. No, always, it's one part of this. It's like,
Yeah, because we get, people.
always maintain the changes that you made in order to get to that point. And then we always do this. Any other questions? Nope. Thank you.
Thank you.
I
Again,
just have
Dr.
one
Dan.
more question.
One more question, Dr. Dan.
I just wanted to ask, in terms of smoke meats,
even though it might be smoked turkey or smoked sausages, is that still a problem in the diet because of the salt that's in the smoke? Well, if it's smoked processed meat, sausages, well, you know, like smoked turkey, wings or whatever. It's too bad if you don't eat a lot of it. Being smoked also has some other issues now in terms of other carbohydrates and things.
Yes.
And that can lead to increased risk for cancer. Different things. So you don't want to eat a lot of quote unquote smoked things. I don't know, it's really good. But, you know, anything in moderation also is good. I'm not saying cut out all, everything, but you have to be mindful of what you're doing, what you're eating, and just know that you can't drink a whole case of pop in a week. You just can't. Well, you can, but I wouldn't advise it. So you just need to do things in moderation. But again, if you're pre-diabetic, you have to make some pretty significant changes in your lifestyle. And once you get used to that and make those changes, so just something like getting in the habit of exercising every day, that goes a long way to keeping your blood sugars low. So those are the sorts of things that, and, you know, congratulations to you for getting off your medications and getting your numbers back to me.
Thank you, Dr. Denver, and thank you for the excellent question. Okay, so two things related to pre-diabetes, cardiac health, men's health, your overall health. We have Blue Cross Blue Shield in the house with a farmer's market out front. When you talk about dietary changes, not being on a diet, but dietary changes, things that come out of the earth are best for you. So Blue Cross Blue Shield, they're out there with fresh produce. Make sure you grab some. But like Sister Joan was saying, that should be half of your plate. Fresh produce, fruit, vegetables should be half of what's on your plate. So if you could stop by Kimberly Polk's table, Blue Cross Blue Shield, before you leave today. And then also, when we talk about prostate cancer, in men, we measure their PSA level in their bloodstream. For cardiac health, speaking of cholesterol, we look at what we call the lipid panel, and we look at your good cholesterol, your bad cholesterol. For pre-diabetes, we look at the hemoglobin A1C, which is also another blood draw. And so we brought a phlebotomist with us today, and we have Tia in the house as a phlebotomist. She's also a walking lab. Tia, do you want to talk about your services? Okay. Yeah, and then we'll bring our next speaker. Come on, Tia, because this is important, because now they have mobile labs. So you can go to the doctor, have your lab drawn, and you have your lab drawn outside the doctor's office, and the labs can be sent to your doctor, but I'll introduce you to Tia.
Okay, yeah, so like she was saying, I'm Tia, I own TC Medical Services, we're a mobile phlebotomy. Up here, so what we do, we travel to the house, draw blood, we do urine. We have mobile x-rays too, so we're connected to our own lab, so when the lab's done, I'll just drop it off, and we have those results to you for your provider. So you have options now to have blood work done, you know, when you go to the doctor, or you can call us, and we just come out at your convenience, to keep everything done.
Thank you, Tia. Also, if you wanted to set up something in your office, for you and your office mates, that can occur too. If you have a sports team, and you need lab drawn adults, children, just know that that service is available, okay? And I'll say that the best thing you can do for your health is, like Dr. Gregg said at the beginning, is take ownership of your health. And so you don't know what you don't know. I did not know I was a pre-diabetic until during the pandemic. We had Tia come in and partner with us on looking at vitamin D, because we know vitamin D can boost your immune system. And so during the pandemic, we were trying to work on boosting everybody's vitamin D level. It's good for your overall health, but also especially good for your vitamin for your immune system. Tia drew our blood work. She also did the hemoglobin A1C on me, and that's when I found out that I was pre-diabetic. So you don't know what you don't know, get your numbers drawn. And then now I will bring to you our very next speaker, and after Dr. Nikki, we are going to take a 20-minute break so we can visit our vendors. But Dr. Nikki, if you can come up and speak to another extremely important topic, breast health. Thank you so much for saying yes. And then if you can tell them a little bit about yourself and what you do before you jump into your presentation. And this is important for men and women. I know when we think breast, we think women, but I'm sure she has it in her stats, so for the men. And then we'll, if you just tell them, next slide. You need the light up, because she can put the light up.
I just need the light for 1 moment, please.
Okay. Is that on? Yes. Okay.
Okay, all right, so whatever you need to do now.
She's gonna pull up these slides for a moment.
Yeah,
That was
that's
the
fine.
last,
Just email
the
me.
one I just sent you.
Okay, y'all give me a minute so she can. All right, good morning. First of all, everybody looks tired, you're sitting down, so stand up.
Thank you.
Stand up. All right, let's just do a little bit of stretching. Stretch side to side. Just get the blood moving a little bit. Right. Roll your arms. So do this at any point in the day. Go back. We're all kind of hunched over. Just side to side. So as you have heard all day, moving your body is one of the most important things that you can do, and that will be true for breast health. Now, I will not make you do what I do every morning, which is push-ups. But I want you to all get to a point where every morning, after you do your devotion, you do some type of movement for your body. My name is Gamela Pierre. I'm an OBGYN. I'm out of Silver Cross Hospital. I've been in this area for 21 years now. I'm originally from Texas. Moved here 21 years ago, started private practice and never left. And so I've been a member of this South suburban community for that long. And I was asked to talk to you about breast health. And I said, well, do people want to hear about that? It's not October. Don't we only hear about breast health during October? No. Hey, so for me, every day is Breast Awareness Day, Breast Health Awareness Day. Because every day, all day, I take care of women, and I have to discuss with all patients breast health awareness. So it's not just an October once a year thing. So I hope people don't think about it as such. I think they're working on these slides. But
You can get started in,
it doesn't matter. We don't need slides. Listen. All right. So I'm wearing pink because it is the color of breast cancer awareness. And yes, I'm an OBGYN, so yes, I take care of a lot of patients with breast cancer. But in June of 2009, I had two of my closest, well, one close family member and one of my best friends develop breast cancer at the same time. And it was a very stressful time, obviously, for them, but for me. Even though I'm an OBGYN, having to watch them navigate what that meant, getting diagnosed, going through the treatment. Fortunately, we are since 2009, so we're well over a decade out and we're both doing well. But what it tells you is that breast cancer will probably affect everybody in here on one level or another. Either with you yourself, with someone that you know, with a family member, with a friend, and it doesn't have to be a woman, it can be a man. So it is important for all of us. And it's not just older women. I have taken care of many young women with breast cancer. I've taken care of pregnant women with breast cancer. I actually have a pregnant woman now who just delivered 35 weeks. We delivered her early so that she could start her breast cancer treatment. So, even though it's not October, it still matters. All right, what is breast cancer? What is cancer? You hear this horrible C word and you go, I don't even really know what that means. Well, cancer is an abnormal growth of tissue. All of us have cancer cells in our body as we speak. What happens is we have regulators in our body to stop those cancer cells from growing. So we have other cells which are specialized and they're designed to actually halt cancer from happening. So cancer is always happening, but we've got good immune system, specialized cells to stop things from going haywire. Well, when our good cells aren't able to do what they need, or the regulations aren't able to do what they're supposed to do, the cancer cells can now take over. They can be in any place in your body. In the breast is made of ducts, milk ducts. You think about how the baby gets the milk. It's got lobes of the breast. And then there's a lot of fat in the breast, and there's a whole bunch of other tissue. Any part of the breast can develop cancerous cells. Any part of your whole body actually can develop a cancerous cell. Most commonly, we see people with either duct or lobe cancer, but you could develop cancer anywhere. So why does this happen? And if you think about when I tell you why this happens, it will make sense about all the things that you've heard all morning about why we can do some things to prevent disease. Well, why does this happen? Well, if our bodies become inflamed and our good cells that are supposed to be fighting things aren't able to fight things anymore, now the cancer cells can start to grow. So if we develop inflammation in our body because our bodies are not getting the nutrients that it needs, now we have suppressed the good cells and we're allowing cancer cells to grow. Same is true for diabetes. Same is true for heart disease. You keep hearing this word inflammation. Well, when we don't check the inflammation in our bodies can wreak havoc on us. So we actually have everything internally that we need, but we have to feed it properly. We have to exercise it properly. We have to give it the food, the nourishment, and then not give it what it doesn't need. And we have a lot of things that we give it that it doesn't need. Food, alcohol, tobacco, lack of sleep, stress. I could keep going. More things we give it that it doesn't need than giving it what it does need. So the whole overarching theme of today is really your wellness, because your wellness affects everything from here to here and everything in between and every organ system in between. All right, I was going to make you guys pull out your phone and do a quiz. I was like, all right, that's too much. People are tired. They don't want to do quizzes. Nobody likes quizzes. But how common do you think breast cancer is? Now, I had a little, let me see if I can do it. If we had to guess, we're going to say, we're just going to throw out 4 numbers and you decide what you think. 1 in 5 people, 1 in 10 people, 1 in 25 people, or 1 in 50. So basically we're saying, do we think it's really common, like 1 in 5, if we count 5 people out in this room, we're going to say at least one of those has breast cancer. Or do we say, well, we need 50 people before we get one breast cancer? Or anything in between. Anybody want to guess? I don't have any prizes, so if you guess, we're going to get a round of applause. We got a 1 in 5. We got a 1 in 50.
1 in 10.
We got a 1 in 10. There's only one other one left. So we can say it. We got a 1 in 20. All right, well, everybody clap because somebody got it right. All right, so breast cancer is actually 1 in 8. So the 1 in 10 is the closest number. So that means if you find 8 people, it's a little less common in men, but not uncommon. And I have several patients whose fathers actually had breast cancer. But if you find 1 in 8 women 8 women, you're gonna find one of them with breast cancer. You know 8 women, so that's like, wow, that's not a small number. For the United States, breast cancer is the most common, technically it's the second most common cancer that we have diagnosed. The second most common cancer. Anybody want to guess the first? You won't guess it. I'll tell you, it's skin cancer. Skin cancer is actually very common. It gets treated and moved on pretty quickly. But breast cancer is the second most common cancer diagnosed. Now that doesn't mean it's the cancer that kills most people. That's not the cancer that kills most people, except in our community. African American community, breast cancer is the #1 cancer killer. In non-Hispanic, non-Black community, that drops below lung cancer. Bottom line is it's still really high, but it's not #1. And I think most people just assume that breast cancer is the most common cancer killer. But what's important to understand about the African American community is that it's higher likelihood of killing you. And 1 is because it's usually younger patients. And 2 is because it's more aggressive. And 3 is because it's less amenable to treatment. So we'll talk about, just generalized treatments, but breast cancer is actually a very treatable disease, especially when it's caught early. But if you don't diagnose it, and you don't have a good way to treat it because it's the type of cancer, then your risk of dying from it are actually significantly higher. So, we can go to the next slide. Okay, risk factors. We keep talking about. Now, some risk factors you cannot do anything about. Who your mother and your father is, you're stuck with those people. Genetics, you can't do anything about that. You cannot do anything whether you're male or female. I'll leave that right there. I will not get into any other conversation about that. You cannot do anything about your age. You can want to be younger, but you can't make yourself. You can't do anything about your race. You can't do anything about your genetics. So not only can you not do anything about this, don't worry about it. Don't go around beating up your family because you don't like their genetics. We all have things in our family that we do and do not like. Don't worry about it. But we have a lot more things that we actually can control. Now, some things on this list, or actually, this list was kind of funny because there's a list that they'll talk about a few other things like breastfeeding. And in some lists, you'll see that as a controllable factor. In some lists, you'll see that as a non-controllable factor. Hormones, that's something that is for the most part controllable. But what we can control, we can control ourselves, we can exercise our bodies, we can control what we put into our mouths, we can control the alcohol that we consume. And you go, wait a minute, they said drink alcohol. They said this a few years ago, drink red wine, it's good for our health, and now they're telling us it's gonna kill us. Okay, the idea is perhaps a glass, small glass, of red wine can be helpful a few times a week, maybe even once a day. That is very different from let me knock back a 6-pack every day or a bottle of wine every day. So keep things in perspective because 1 minute they'll say, well, they told us to do this and now they're telling us to do that. So it doesn't necessarily mean that 0 alcohol is the goal. For some people that is the goal, but very, very minimal alcohol is probably fine and may help your heart health. But anything beyond that, we know is going to contribute to obesity because drinking your calories is going to contribute to cancer, cardiac disease, coronary disease, etc. You can't really control if you had radiation to your chest. Nobody's walking around saying, can you put radiation on my chest? Some people have had that because they've had other cancers before or they had an accident and they needed a CT scan multiple times. So that's not that controllable. And it's hard. You're going to be in the hospital demanding, no, I don't want a CAT scan. I just had a major accident because I might get breast cancer. So that's a little bit wishy-washy. Smoking, we have control, we definitely have control of our weight. We have control over hormones, and that's a little bit controversial. I'll leave that for you to discuss with your provider, because not all hormones are created equally, and nor does it mean that every hormone is bad. So we all get into this thing, well, I don't want any hormone because it's gonna kill me. Well, that's not necessarily true, but there are some hormonal components to breast cancer that you should be mindful of. Now, if you happen to be a woman who's in reproductive age and you can breastfeed, breastfeeding does actually have some protective effect against breast cancer. Now, some people can't breastfeed, so I don't put it in the control category because they may have other reasons that they can't breastfeed. But if it's something that you're like, well, I don't really want to breastfeed, you might say, okay, well, maybe this kid is going to actually give me some benefits. It's not a bad thing. You can look at it that way. What age you started having your periods and when you stopped having your period, those all contribute, but we don't have control over that, so don't focus on anything like that. But the ones that are modifiable, you really need to be mindful of those. Now, okay. Let's talk about screening. What screening techniques has anybody heard for breast cancer? Mammogram, anything else?
Breast
Self-exam, self-exam. Any other ones? Okay.
Blood test?
Blood test? No, there's not. It would be nice if there was a blood test. I think I'd rather get stuff than a mammogram. I'm not sure. I'm not sure. I don't like needles, but I don't like mammograms.
The ultrasound.
Ultrasound,
Tomography.
tomosynthesis, yes, and thermography. Did you say thermography?
I thought it was tomography.
So all of those are different modalities to help look for breast cancer. So the first thing is awareness. That's why they asked me to talk about this. Because some people think, well, you can't get breast cancer until you're 70. Or I can't get breast cancer because I'm white, or because I'm black, or because I'm a man, or because I'm a woman. So first of all is awareness that everybody has a potential risk of breast cancer. The second thing is understanding the breast tissue. Who understands their breast tissue? I don't, It's kind of odd. Changes month to month, changes in decades, changes when you have a baby, changes when you gain weight, it changes when you lose weight. They used to recommend every month you have to do a breast exam. Does everybody remember that?
Yeah.
Some of you are older, some of you are too young, so you don't know what I'm talking about. Well, guess what? They don't actually recommend that anymore. It's interesting. People say, well, why? Should I not touch my breast? Well, I didn't say that. The reason they don't recommend it is because what they have found is that in a society, and I'm going to use that term kind of loosely, with access to screening like mammogram and clinical exams, it hasn't found to be that much more helpful. Now that doesn't mean, okay, just don't ever touch your breast again. But they also found that people felt guilty because they didn't diagnose their breast cancer, and it just wasn't showing that it was helpful enough. So what I tell patients is, get to know your breast. How do I do that? Well, you have to touch it. That's weird for some people. I don't want to touch my breast. That's not my job. Well, you gotta wash.
I used to tell them somebody should touch her.
Somebody.
It's not you.
Somebody not you.
Somebody should be familiar.
The problem with that is, if it's a different somebody, or if the somebody's not paying close attention. So, it could be somebody, but it probably needs to be you. And just get over it. It's not weird, you're not feeling yourself, you're doing things like you brush your teeth. You're not over there going, oh, I shouldn't be brushing my teeth. That's not, something. No, it's just another part of your body that requires evaluation. The best way to do it is if you still have a period the week after, because that's when things are the least lumpy and bumpy. They're really lumpy and bumpy right before, so don't touch stuff before. Everything is going to feel weird to you. So the least lumpy and bumpy after. So that's how then you just get used to what your breasts feel like. It doesn't mean you need to be checking your breast every day or even every week or every month. But randomly you say, oh, I need to just check and make sure that everything, these lumps still feel the same. I always say the best way to do it is after you go to the doctor. And the doctor will say, these are your normal lumps, this is not a normal lump. Then you go, oh, okay, that's my normal lump. And then every lump doesn't feel like, oh my God, is this breast cancer? You say, oh, that's just my lump, and that's fine. Oh, wait, that lump used to be smaller, it didn't hurt, or now it feels different. Those are things that you can pay attention to. So self-exam is important. So I don't want to discount it, but it's not that rigorous. Like we used to have that little shower card you have to check off. Oh my God, I didn't do it. I didn't do it. So clinical exam, I'm an OBGYN. Guess what I do every day? I'll go to the breast exam. So that's my job. If you don't come to see your OBGYN, you see your internist, and people, internists don't want to touch the breast. They're like, no, go see your OBGYN. But ideally, somebody at some point should probably help you to make sure that what you're feeling, you understand what you're feeling. Then you get to the magic age of mammograms. I'm not going to stand here and say mammograms don't hurt. That would be a lie. I think mammograms hurt. Yes. I am overdue for my mammogram as I stand here by 1 month because I'm like, oh boy. But I'll tell you, it's not that I'm overdue because it's going to hurt. I'm overdue because I'm afraid, like most people. I take care of breast cancer patients all day, and yet I am still afraid to go for my mammogram. And they're literally, here's my office, they're in the next room, next to where I'm examining patients, where I go get your mammogram. They're sitting there waiting, doctor. I'm like, I'll do it next week. Now I'm gonna get it done. I'm gonna get it done. But the point I'm making is that many of us have an anxiety about the mammogram. Okay, guess what? If it hurts, it's uncomfortable, it is 10 minutes of your life in a year. Move on. We do way more things that are uncomfortable. We wear tight clothes, we try to fit clothes that are too small, we're stuck in our gut, we're eating, our stomach is puffed out because we ate too much, and nobody's like, well, I'm not gonna eat again. You still eat, and the next time you might eat more, and you're like, oh, Thanksgiving, and I'm like, yeah. So we do things that are uncomfortable, but in the scheme of things, we're not children. It's 10 minutes of our lives. And yes, some people it's more uncomfortable taking aspirin or a Advil. That helps some people. And then just think, okay, good, I don't have to go through this for another year. So I'm not going to pretend it's not uncomfortable. Now, who should be getting these screenings? Does anybody know when you should be getting a mammogram? 40. So here's the funny thing. Yes, it is 40. And there are several different governing bodies who decide when you should do stuff. So my governing body, which is the American College of OBGYN, I do everything they say, that way I try not to get sued. They've always said 40 every year. That's what I do. 40 every year, I don't want to discuss it. Well, another very prominent governing body in the United States didn't say that. They said 50. And maybe if you're 40, maybe you can talk about it, but no more often than every 2 years, but really 50 in every 2 years. That was the United States Preventive Task Force. The American College, the American Cancer Society was more with the American College of OBGYN, and they were more frequent. But people were afraid in the United States Task Force that we were doing too many mammograms. So I have a lot of people going, I'm not going to get a mammogram, that's what the U.S. Task Force said. Well, guess what the U.S. Task Force is now saying? They're late to the party, but they are now deciding that, well, maybe we should start mammograms at 40. Now, how they got this late, it's been 10 years that they've had this recommendation, but they are actually in the process. So at this point, pretty much all the governing bodies in the United States are going to be on board with mammograms start at 40. Some people feel every 2 years is fine, depending on your patient, depending on the patient's tolerance. They say, I'm not doing that squeezing thing every year. I'll do it every year, and people feel that may be reasonable. But 40 is about the age. We start screening. Now, the screening might be different if your family history is significant. Significant is that you had a family member who had breast cancer premenopausal. So if you have a mother who had breast cancer and she was 40 and you're 30 and you come and see me, we talk about screening. It might not be a mammogram because that's not really appropriate for you, but we do things earlier because we're hoping that if you're like your mom and you're gonna get breast cancer when you're 40, we already started looking when you were 30. So it does change based on family history, but sport. So I have a lot of 40-year-olds and they come in and they go, oh, you wanna get your mammogram? No. I'll tell you the best thing I did to change that. I brought a mammographer into my office. Literally, they're in my, you get your pap, keep your gown on, you go here, and now they don't have an excuse. So what I recommend is when you go through your annual checkup, make all your appointments the same day. Nobody wants to take all your rest time. You get a babysitter one time, or you get a half a day off of yours. Make your appointments at the same time. And that way, you just check off one. Now don't say, well, couldn't get in for the pap. You can't call at the last minute. No, nobody has appointments. But if you thoughtful about it, and you say, you know what, my birthday's in September, it's an easy time to remember to go around your birthday. So in September, I'm gonna try to get my mammogram appointment, I'm gonna try to get my dental appointment and my pap smear all on the same day. You get all the pain done at once. And I hate the dentist. But you know what? Then you're done. Take your one day off from work, you're done, you did all your stuff, you checked off the box, and now you're not having to deal with the inconvenience of trying to do all these different things. Make it a fun thing. Tell your friends, let's go get our mammograms and go get, you know, it sounds goofy, and it is. It is goofy, and it sounds goofy, but I have a lot of people who come to me, and they're like friends or sisters or mother or daughters, and they come together so they can get their appointments, and then they go for lunch. It's like a thing. Like they have a little spa day, they get their pap, and then so you could do the same thing with your mammogram, and that way the friend who's like, I'm not going, you might be that encourager for her to say, you know what? I know you don't want to go. I don't want to go either. Let's go together. And you'd be surprised how sometimes that let's go together, it helps you and it helps your friend or your sister or your mom or whoever. Somebody should tell me that because I am trying to I'm gonna go. But you know, I'm just being honest. Now, there are alternatives to mammograms because a lot of people go, I heard about this thing called thermography. I want to bring this up because you might hear of it and you go, well, why didn't she tell me about that? Because guess what? They don't even touch your breast. Why aren't we all doing that? That doesn't hurt. It's just a picture of your breast. Well, the problem with this technology is that, number one, it's not FDA approved. Number two, it might work. I'm not even going to stand here and say it doesn't work. We don't know enough about it. And so my concern is that someone will get this, they won't get a mammogram, and they'll take the results and apply it to whatever, and it's not really applicable. So I'm not saying this is the worst thing. I'm saying we don't have enough knowledge about it, and it's not studied enough. So if you hear people talking about, well, you should just get thermography, and your doctor is wrong, and they shouldn't be pushing mammograms, because this doesn't have any radiation. Well, why don't you do this? And in 10 years, maybe. But we've been looking at this for about 20 years, and they haven't come up with any science that suggests this is really over the gold standard, which is mammogram. And you brought up ultrasound. Well, why don't you just get an ultrasound? That doesn't hurt. Because ultrasounds and mammograms look at the breast differently. So you can't really substitute one for another. So they're two different things. Now you hear about MRI. That's really come on the scene. MRIs are great tools. Number one, they're really expensive, and your insurance is never going to pay for it unless. So there's a big category of unless. And maybe in 10 years they'll pay for everybody to get a breast MRI, but right now that's not happening. And then MRIs are not pleasant either. Who wants to stand there with knocking and being still? So, you know, even though it doesn't squeeze and hurt, there's still something there. So, the action items. Remind your friends to get a mammogram. Make a text group. We got text group problem. You get your mammogram. And don't make people feel bad about it, right? Because just because you want them to do it and you care about them, try not to make people feel guilty. You just have to give them support and encouragement and see how you can offer to help them through the process. Now, the next thing I wanted to really talk about is this. This is like my biggest pet peeve as a doctor, and I want it to be your biggest pet peeve as a patient. the anxiety, right? That's what a lot of us are nervous. What did they find? Number one thing in medicine, please, no news is not good news. I hate doctors who say that. I think they're terrible doctors. I'm gonna say it again. If your doctor says no news is good news, fire him or her. That's the dumbest thing I've ever heard. And people say that. No news is just no news. It doesn't mean anything. You know how many people call my cell phone? Well, Bob, your PSA was abnormal. I'm like, I don't know, Bob. I'm not Bob. What was that number? Sometimes I call them back and say, hey, you called Bob. That wasn't me. Sometimes I didn't catch the number. Sometimes I don't think about it. So no news is just no news. Please do not think that no news is good news. Now, one of the federal changes with mammogram is you're actually supposed to get two reports. The place that does your mammogram has to send you notification within 30 days. If your doctor ordered it, by the way, you can have a mammogram. You can just go somewhere and show up and say, I want a mammogram, and the doctor doesn't have to order it. There's good and bad about that. But if your doctor orders a mammogram, then when they get the report, which is usually after you get it, then they usually will send it. So a lot of times you'll get two comments. You'll get one from your doctor who ordered it, or one from the actual mammogram place. So the big thing right now is dense breasts. You probably all got this. They go, breast or dense breast? What do I do with that? Yes. So why do we care about dense breasts? Well, you can make sense, right? The denser something is, the harder it is to see. So it doesn't necessarily mean that dense breasts mean you're going to get cancer. It means it's harder to detect cancer. And so depending on your history, if you have dense breasts, they may recommend additional screening like an MRI. So you have a strong family history and dense breasts, we can't really see. So those are times where your doctor might recommend an MRI, and the insurance company may cover an MRI. So when you see these results, that's one that they now have to report. As of maybe 2 years ago, they have to say, you have breast dense. Dense breast, dense breast. And therefore you go, what does that mean? What's wrong with my breast? It's not that it's bad or good, it's bad for trying to interpret information, or it's difficult. So that's what that means, and then that means you say, I might need additional screening just because it's a little harder to see, it's harder to read. So I think that there's some resources. Now, the way insurance is now, they have to cover screening. Insurance companies change their tune every day. If you come to me and you say, I have a lump in my breast, and I code it as diagnostic, your insurance company doesn't have to cover that. You go, well, don't write that I have a lump in my breast. Okay, well, if you have a lump in your breast, I have to write that. But the insurance company doesn't have to cover that. They do cover screening. So screening means I'm here, I'm feeling great, I'm getting a mammogram because I'm 45, and that's what we do. I go into the doctor, or my breast has a lump in it, or it feels funny, or something else, or the doctor feels something. That's a diagnostic. The technology used is different, the way it's read is different, and so the way your insurance company pays for it is different. So I make that point because people get upset and they go, I just coded it like you can't do that. But the point is, your insurance should cover screening mammograms. We in the state of Illinois have access to free mammograms. The Illinois Breast and Cervical Cancer Program is a great program. It's been around for at least 20 or 30 years. I didn't put the phone number up, but I have the number, the name. You just Google that. And when you Google it, it will show you the list of resources. It will show you who qualifies. It will show you where to go. It's also true for pap smears, so you can also get access to free pap. So there is no reason, insurance-wise, that you shouldn't be able to get a mammogram. Barriers to mammograms are taking off work. You can do mobile mammography now, look it up. They have it in all sorts of places. Try to go to a place where you could do everything on the same day or at the same time. Like I said, I happen to have that now. I didn't have that last year this time. So reduce, the community has to try to reduce the barrier. But money, in terms of paying for it, shouldn't be. Money in terms of taking off from work, that's a reality. But if you try to look for places that are on Sundays, a lot of places now are trying to offer other days of the week, time off and late time. But you gotta schedule some of these things out. You cannot call today and say, well, they didn't have time to see me. No, not next week. But you can just be thinking about it and getting stuff scheduled. So, a little bit about breast health, even in May, I still care about breast health. I don't wait until October to wear pink. Does anybody have any questions? So cervical cancer, which is really related to pap smear screening, it's actually on the rise. And you go, well, that's messed up, because they told me every time I go, I don't need a pap smear. Well, guess what they figured out? Oh, we're gonna miss something. When this first started in 2012, the recommendation from the governing body was pap smear. Now, it's not just everybody gets a pap every 3 months. There are certain criteria that your pap has to meet in order for that to be true. But I had a patient who, she met the criteria where we should not do a pap for 3 more years. She had negative HPV, she had a normal pap. Well, the next year, because this was new, my nurse put out the pap, and I always do an exam. Even though I'm not doing a pap, I always look at the cervix. So my nurse, by habit, she put out the pap, I did the pap, and it came back as a grade 3, really bad pap. I was like, oh my God, I shouldn't have even done this pap on this lady. So I went to the conference and I said, hey, what do you think about this? We should have done a pap on this lady. She was in the category for routine pap in 3 years. And he said, you're going to miss something. That's the answer. And I was like, wow, that sounds really bad. I said, you're going to miss something. Well, then what happened? Then they stretched it out to 5 years. So now some doctors, and I'm not in the 5-year group, not doing it. Now the recommendation is, okay, you had the normal pap and your HPV 5 years. So now what are they seeing? Cervical cancer is on the upward. Now, that lady was probably a fluke, although I've actually had about 3 of them. But I will tell you this. 3 years becomes 5 years. 5 years becomes 10 years. And people don't know when they got what number. If I ask all of you, when was your last pap? About half of you might get it right in the year, especially with COVID. People were like, I wasn't here last year. No, it was COVID. No, you weren't here. They go, oh, and then already that's 5 years. So now you are running into people, and then people move, they forget, they didn't get a new doctor. So I am really squeamish. I'm comfortable 3 years in my practice because I have a nurse who's very anal, and if you aren't here in 3 years, regardless of where you are now, if you move, and she sends you a letter and you move, you can't fix it. But she's pretty anal about it. She knows. Although she didn't catch that I hadn't done my pap in 3 years. She just assumed I would get it done, but I'm just bad with that. I got it. But she's very anal with checking off the boxes. But I have a pretty close-knit practice where I know I have access to my patients. But if I had a practice where the patients were more fluid, where they were young, or they were moving, or they were more transient, I would not do that as a practice. So the cervical health is still covered by the Illinois Consortium, but you do have to be really careful and mindful, and you have to know what your pap smear said. Again, it's not the no news. You can't just go with normal. And this is not a dig at the primary cares, but they all don't know that they have to order the HPV. Now, gynecologists, that's your bread and butter. You should know that. But if your primary does or whoever does it, you need to make sure what did they order and what exactly did it show. Because then sometimes people have sort of abnormal, sort of normal, and they didn't really need a pap very good with understanding what was done to you and truly understanding what the results are. And then dealing with whatever the results are.
I just choose to go every year.
Well, wait a minute. I didn't say you didn't go every year.
No, but I'm just saying.
And you should go every, I wanna make that point. I didn't say you didn't go to your doctor every year.
Right.
I said they don't do a PAP every year. That's two different things. And people mistake it for being the same. So what happens is, I heard I don't need a PAP for 3 years, I'm not going to the doctor for 3 years. That's not right. Because what happens, number one, is when you go, then they go, oh, we missed that last year. Or, I've had this happen. I called you 3 times last year and you never called me back. Your PAP was abnormal last year. You did? Well, because you're used to coming every year, now we address that. So that's number one. So I am a firm believer that 3-year PAP does not mean 3 years of skipping your doctor. And people really get confused on that. I know you're not.
No,
People
what
are
I'm saying
saying
is that I choose to go for my PAP simply because of my history.
Right. Well, your history dictates differently, and your insurance dictates differently. Some insurance companies will not cover it, and I have to have patients sign a waiver. And some insurance companies, they don't really care if you get it. I have a feeling we're gonna see a little bit different, but it is somewhat financial with the 5-year plan, but I think it's very interesting that we have HPV vaccine and we still have cervical cancer around.
I have a question, Dr. Vicky. You did get to step,
So you can stop your PAP. I stop anywhere between 65 and 70, depending on the patient's history. And mammogram, it's sort of 75, but it kind of depends. If you are 75 and you have a long life expectancy and you say, if I have breast cancer, I would treat, then you would keep doing a mammogram. If you say, I'm not doing that, I don't care, I'm 80 or I'm 74, and if you find breast cancer today, I'm not doing any of that, then I don't do a mammogram. Because you're doing a mammogram to treat something. So if you're not going to treat something, and it's not wrong, it's just you have to give patients time. So about 75 for mammograms, somewhere between 65 and 70 caps. Yes.
My grandmother she passed away from breast cancer. And I know you said like if you're like a parent or somebody had breast cancer, you should get checked. They had it before perimenopause, you should get checked early. My grandmother, she was diagnosed, she was in like the late 60s, early 70s. So like I don't know if like how soon like I should get checked. Should I still wait till like 40 or should I get mammogram sooner than that?
So that's a good question. Generally speaking, it's a first degree relative. So first degree means your daughter, your mother, your sister. Right there. It's usually, that is where your strongest risk factor for genetics, and it's usually if they had breast cancer before they went through menopause. Which for most people is about 50 plus or minus. Some people also will have a breast cancer gene, not just BRCA, that's the one we all know, but there's a whole list of them right now. So in somebody with, that it's your grandmother and she was menopausal, you would probably, I don't know the rest of your history, be doing it at the routine time. So you go with that with your doctor, and if they didn't see anything else, they probably put you in the routine.
So if you find a lump, can you still take advantage of this free screening?
That's a good question. I think if you have a lump, you still call them, okay? Because they have criteria for the Illinois Consortium. You probably would, because it's not just like you show up here and it's free screening. You have to go through an application, et cetera, et cetera. They want to make sure they're using resources. But at that point, you might say, I actually have a lump. I guarantee you that many people who actually had some symptom have gone through this process of the consortium, and then their job is to kind of navigate them through wherever they can.
I just wanted to make some comment real quick. I know we're gonna wrap up so we can go visit the vendors. We were talking about the thermography. So I've had that done twice, and so it's a routine to go. This sets the gate where you are, and when you come back, we'll see if there's any changes. So we didn't notice any changes, but then I went and had my mammogram, and there was something there. So I was trying something different because I didn't want the. And they always said that I had dense breast. So the thermogram didn't pick up anything. Not to know that, not to say it wasn't there, but I had a lump, but it wasn't cancerous, so, but it was still.
Thank you for saying that. because a lot of people I get, and so I appreciate you being a patient, saying, I want to do something a little different, and this is my experience, so I appreciate you sharing. Thank you.
Thank you very much. And every health fair I ever host, I try and have them speak on breast health, because it's that important, because so many of us are dying from breast cancer. Screening can also help early detection and getting treatment and increase your chance of survival. So we're gonna take a break now. Thank you to all of our speakers. If you have any questions, don't forget you can get in contact with us. We can also get you the flyer. But I want to announce 2 vendors who are here for sign up. So Tracy, you want to come from Versity? We have we're signing up for the blood drive that we're going to have next week. 2-day blood drive. So we have Versity here who are our partners always for blood donation. And then also we have Be the Match here. We're gonna have her speak too because they're here swabbing cheeks so that we can get some minorities on the bone marrow donation list. And I'll hand it to you and then we'll take a break. And then when we come back, we're gonna have discussions on mental health in both adult and youth and the resources that are available. Okay, go ahead.
So hello everyone, my name is Tracy Jaramillo and I am with University Blood Centers of Illinois. And we are doing a 2-day blood drive at the Living Springs Church to represent the Southwood area. And there's a lot of churches on here that are all partnered with us to do this blood drive. It's on Thursday and Friday, and Thursday is from 3 to 7 p.m. and Friday is from 12 to 4. And you know, we talked about diversity and all those other things and be your best match. Well, we have a campaign as well about being your best match. Blood cannot be manufactured. It can't. It's gotta come from us. And it is your best match is you and somebody like you. I would not be a good match for people in this room, but you all would be a great match for each one of you. There's diseases that affect each of us. And it's important that we understand those and that we understand why it's important to get blood. And there's a lot of misconceptions about getting blood. Does anybody know the number 1 reason why we don't get blood? Anyone? I guess? Needles? I heard. Anybody else? I heard. Get infected, right? Number 1 reason, they're not asked. Nobody ever asked them. That's the number 1 reason, ironically. So we at Versity are a community blood bank or blood service, and we actually keep the blood that you donate in your community. So we partner with hospitals all across the Chicagoland area and Northwest Indiana.
Thank you very much. And the sign-up table is out there and it will be there for the
You had a phone call that came in.
So
Okay,
there
that's
are
fine.
multiple